Yes, thank you. Good evening or good afternoon, everyone, according to your time zone. Thanks so much for joining us in this session, and I'm really happy again to join such valuable webinars conducted by the IRC-RCOG Egypt. My name is Mohammed Hassan, and I will joyfully be with all of you for more than an hour with my dearest professor Yasser Abu Talib, the chairman of IRC-RCOG Egypt and the professor of Ops and Gynae, Ain Shams University and Military College as well as my dear colleague and my dear mentor, Professor Sameh Hussein Salama. He is the head of the OB-GYN department in National Research Center and a member of Committee of ERC in Egypt. Today, I would like also to welcome everyone in the room and welcoming the marketing house. As usual, they are doing a great, extraordinary job in preparation and in finalizing this session in this wonderful way. Thanks so much, marketing house. And last but not least, the Pfizer company, which is really supporting the medical field in Egypt as usual for many years. Thanks, Pfizer, so much. And we will be happy to start our session right now with a welcoming word by Dr. Yasser. Professor Yasser, please, mic is yours.
Okay, that's fine. So to start with, good morning or good afternoon or whatever. I'm pleased actually to meet you as usual. We used to have webinars every month or every 2 weeks just to meet all of you, to have a very strong bond between all of us, both social bonding and scientific bonding as well. So it's great pleasure actually to meet you again. It gives me a great honor and pleasure to spread the idea of new vaccines, which coming up in the market very soon. And we adopted the policy of spreading this idea because it's considered as national program in Egypt to markedly reduce the neonatal mortality because of respiratory problems. So it's a new vaccine which will be launched, I think, in September by Pfizer in Egypt, and it's aimed mainly to prevent respiratory syncytial virus infection during pregnancy and after delivery immediately. So the commonest cause of mortality during the first 8 months after delivery is GIT problem and in the form of gastroenteritis and respiratory problem as well. For prevention of the respiratory problem, I think the respiratory syncytial virus is one of the commonest organisms which might be associated with mortality of the babies after delivery. That's why we were desperate actually to adopt the idea of preventing and reducing the neonatal mortality all over Egypt and all over the world as well. That's why we tried by all means to contact this product that bring it to Egypt to spread this idea. So it's our pleasure actually to spread this idea. That's why we will discuss the viral infection during pregnancy from the Ops and Gynae point of view. The next week, we are going to discuss effect of different viral infection, especially respiratory syncytial virus. You later, after 2 or 3 weeks, to a face-to-face meeting to discuss in details the different viral or neonatal infection or perinatal infection, especially from the point of view of the maternal side and neonatal side, in a combined meeting between neonatologists and gynecologists as well. Okay, and to let everyone to know our adoption to the national program for this problem by using this vaccine. So I'm very happy actually to participate in that as part of the national program to reduce neonatal mortality in Egypt. As well, it's my great pleasure to invite you to our coming meeting or International Congress, which will be held between the period between 24th and 25th of September. And it will include lots and lots and lots of surprises, including many consultants and many professors coming from all over the world, from Italy, from America, from India, and from England as well. And all of them are just a unique person in their fields. And we're going to meet them in the Congress to discuss new issues. And around this Congress, we'll have many workshops. As you know, that the International Representative Committee of the Royal College in Egypt is very interested in hands-on workshops, which is not done all over the world except in Egypt. It's total laparoscopic hysterectomy, urogynecology course, and pelvic floor surgery. And what's new is artificial intelligence in medicine and virtual reality as well. And as well, oncology and colposcopy. So the point is, you are going to do everything you yourself, using your hands under supervision of consultant from England and from Egypt, just to make you very professional in this issue. Looking forward actually to see all of you and to contact us and to register in the Congress, and as well to register in our training programs, which is unique for everyone. Thank you very much, and looking forward to see all of you soon and to enjoy our program in National Program for Reduction of Neonatal Mortality using Respiratory Syncytial Virus Vaccine. Thank you very much. Okay. So I think the first presenter, Muhammad.
Yes, thank you, Professor Yasser, so much for this intro. And I think the first presentation will be done by Professor Sameh Salama, my dearest mentor and friend. He is the head of OB-GYN and Fertility Department in National Research Center, the FRCOG, the Fellow of Royal College of Obstetricians and Gynecologists, and a figure member of the committee. Thank you, Professor Sameh, for being with us. And please, you can start the presentation. We are all ears. Thank you.
Thank you, Professor Dr. Yasser, for your introduction. Thank you, Dr. Muhammad, my dear friend. And all of you, please excuse us if there is a troubleshooting with the internet, because, you know, it's like a national problem. So if we are losing connection at any time, we're gonna try to restart it or recatch it again. So let's start sharing our screen. Is it appearing like this? Okay, so our presentation today will be on the COVID-19 and influenza in pregnancy. I know this is a very common thing that you would encounter in your practice. Just you have a patient and saying, I'm feverish, I'm sneezing, I'm coughing. So it could be a COVID, it could be an influenza. So it's a very common thing. The goal and why it matters, this presentation, just to understand what's the impact of both diseases on pregnancy. Firstly, we need to review the current recommendation, how to prevent it. Pregnancy can cause immunological and physiological changes, as we all know, and this makes pregnant women more vulnerable to problems with those disease. Increased risk of severe disease from respiratory virus. This is general in any pregnant woman. If you encounter a respiratory virus, you can end up with more or severe disease. So respiratory infection can be a cause of significant maternal and fetal morbidity. So let's pass through quickly the immunological change that can happen in pregnancy. We all know that in pregnancy, there is some alteration in the immune balance. So there is a shifting from what we are called the cell-mediated immunity to the humoral immunity. And this is actually, it's something physiological happen, makes the body of the pregnant woman can tolerate what we are calling the semi-foreign fetus. So it reduces the ability to reject this fetus, but on the other hand, it reduces the ability to fight any infection. Inflammatory response actually is decreased during, especially the second trimester. It's like an pro-inflammatory status in the first and third trimester, but in the second, it's an anti-inflammatory status, which means the response in the form of fever, inflammation process is decreased during pregnancy, makes it cause a delayed detection of any virus coming to the body. And the immune tolerance to the fetus is upregulated, so it prevents the attacking of the fetus by the body antibodies, and this makes the ability to fight infection also decreased. Again, we have other physiological changes in pregnancy, makes a pregnant woman may suffer from complications if she counter an infection. So firstly, respiratory system, there's a decrease in the lung capacity, as we know, because it has been pressed with the pregnant uterus. The oxygen demand and the tidal volume is increased. So this makes the pregnant woman more prone to hypoxia and respiratory decompensation. Talking about the cardiovascular system, there is increase in the blood volume, which means there is an extra effort has been put on lungs and heart, especially during if you're ill. And this could contribute to cardiopulmonary complication, severe infection. There is mucosal swellings, always pregnant women have a congested nasal mucosa, making them sometimes they are like sneezing or having some form of sinusitis in pregnancy, bleeding from the nose. This is a very common complaint. So this makes the upper respiratory infection are more severe. And definitely pregnancy is a hypercoagulable status. So this increased the risk of having a blood clot. And this is one of the complications of COVID-19, as we can remember when it was like a big pandemic. Again, there are risk factors makes a pregnant woman more prone to have complications than other one. So if she's obese, if she's asthmatic, if she's diabetic, hypertensive, if she had a delayed access to care, for example, if she's in a rural place or something like that, racial and ethnic disparities, it's not here, but in some countries could be like that. So the question is, we're giving this lecture, is COVID-19 still present? And the clear answer is yes, it is. It's still circulating. It's not disappearing. Maybe it's not the same strength as it was before when we had the pandemic in 2020, 21, and most healthy people now would experience a milder disease. But this is because many of us now are vaccinated. Maybe the strain becomes more weaker, I don't know, but still it is present. However, older people, immunocompromised people who had a chronic illness, and the most important for us are pregnant women still considered a high-risk group for severe infection. And still, COVID can cause a long-term effects like loss of smell, loss of taste, some troubles in the body. It's still present. Maybe, again, it's not that severe like before, but still it's happening. And new variants, it's emerging every season. So sometimes it's very strong, sometimes it's not. So we are not completely safe from COVID-19 because it's changing every year. In many places, it becomes like an endemic, like influenza and flu. So it is present. National vaccination programs, as we said, but still dangerous in some areas, so just don't ignore it. The mode of transmission for influenza and COVID, both of them are coming from or transmitted from respiratory droplets. Maybe the COVID is more even from aerosols. They are both airborne spread, but actually it's more contagious for COVID-19 from the surface. It can come from a contact with the surface, but it is less common. Definitely the transmission from one person to another while in close contact, talking, coughing, sneezing, in crowded place. And for that, I'm always advising any pregnant woman, please try to avoid crowded places. Your husband is going to a crowded place or a party. Please don't put yourself at risk for this. And this should be a clear advice in the beginning of pregnancy. I put this, we're not talking about a common cold, but there is a difference between a common cold and influenza, and should be cautious about this when you are taking a history from a pregnant woman who's saying, I'm complaining from that and that. So common cold, mainly it's caused by rhinovirus. However, influenza, it's influenza virus type A and B. Onset of symptom, the common cold is usually gradual. You start to have like sneezing, coughing, sore throat, and it comes over days. But in influenza, it's coming like a sudden. It's uncommon to have a fever with common cold. So if you have a pregnant woman and she had, I would say, the symptoms of what you are called a cold, and she's feverish, most probably it's an influenza or COVID. It's not a common cold. Okay, so she should be more cautious. Headaches, body aches, fatigue are all mild in common cold, but they are more severe in influenza. On the other hand, stuffy nose, sneezing, and sore throat are more common in a common cold, and it's not in influenza. But the body aches is much more harsh, I would say, in influenza, with more probability of having a chest problem that can reach up to pneumonia, and the duration is longer. So most of us will recover a common cold in 1 or 2 days, but in influenza, it can take up to a week or 2 weeks. The difference, or influenza versus the COVID-19, it's a different virus. This influenza virus, this is the SARS-CoV-2. It's the incubation period for coronavirus might be more longer, up to a couple of weeks. Mostly you get influenza in the winter, but COVID actually, it spreads around the year. So it comes and goes, through different seasons. Still with influenza, you can have a pneumonia, you can have an acute respiratory distress, but it's more definitely common with COVID. Sometimes you encounter a patient with a preterm labor, low birth weight, and you don't know what's the reason. I'm not saying the reason is having such an influenza or a previous history of COVID, but you should put this in mind when you are explaining to the patient. You don't need to search and say it should be that or that, but you say probably you had a history of something like that, and it could be the reason why you deliver preterm or have a low birth weight. Stillbirths can happen in case of COVID, and I have seen cases like this before, and she was in labor and everything was fine, and she had a sudden stillbirth during labor without any explanation, and she had a positive COVID test and fever. Vaccines are safe in both, and the treatment for both is antiviral. So the maternal seasonal influenza, as you were saying, it's pneumonia, increased risk of secondary bacterial infection, which is more dangerous than the disease itself. Dehydration, fever, can it reach this point? Yes, because if you have a severe sore throat, if you really feel sick, sometimes you don't take a proper amount of fluid, especially if you're pregnant with fever, it can go to dehydration, and definitely ARDS, and it may end up in ICU. Fetal risk, we have just mentioned, preterm low birth weight, fetal distress. Fever in pregnancy has been encountered to a possible neural defect, a tubal defect in some researchers, but it's not proven, and a possible miscarriage. And as I'm saying, you have seen definitely many patients who miscarried and said, I was feverish like a week ago or so. Maybe this is a reason. How to prevent? Just take the vaccine. It's an annual vaccine taken in the beginning of the winter, before the beginning of the winter, and it decreases the maternal hospitalization by 50%. And I think it's very prudent for you as a doctor obstetrician to advise every pregnant woman to be vaccinated to take the flu shot, I would say, or vaccine in the beginning of the winter. But just don't leave her. You should advise about this, because actually in pregnancy, you are prone to complication, and you don't have much to do because you are, restricted in many medications. So for the COVID-19 maternal risks, actually, when it appeared, the COVID, it was really surprising because it was thought to be a respiratory disease, but actually it presented with extrapulmonary manifestations like cardiac, kidney, liver. All of us, can remember cases who had multi-organ failure from that disease. So the risk of having a severe illness and ICU admission is definitely higher, and it is linked to increase the risk of preeclampsia. Fetal risks like influenza, but it's more, I would say, harsh. It's the preterm low birth weight, possible vertical transmission, but this is quite uncommon. Change in amniotic fluid index. I've seen some cases with increased amniotic fluid index, decreased. In the era of COVID, it's after you encounter the infection, you found like changes in amniotic fluid. I don't have any evidence about this, but I've seen some cases like that. And placentitis, because the COVID virus can cause inflammation of the placenta, and this could be the reason why they encounter stillbirth or something changing in the placenta, the amniotic fluid index. So those papers have been published. Many papers are published about this. The one on the left is in 2024, and it was saying that COVID-19 infection on pregnancy outcome, it increases adverse outcomes like preterm labor, C-sections, and low birth weight. On the right, this paper, actually one of the authors of this paper, it was in 2021, we assessed the gross and the anomaly problems in babies where the mother have COVID-19. But honestly, it was a pilot study here in Egypt on 30 patients. We did not find a connection between this and this, but still it was a small study. Maybe if it's a larger one, we can find another results. So how to prevent, again, COVID vaccination, despite of having like a bad repetition sometimes, but I mean, most of the research have found that COVID-19 vaccination is safe. It is recommended in pregnancy, protects mother and baby, and vaccinated pregnant women would have a lower rates of severe infection. So it is advised. How to manage? Just give an antiviral. If it's oseltamivir was previous saying it's not safe in pregnancy, now they're saying it is safe, you can use it, and monitor oxygenation. And we can remember in the COVID era, we bring like those pulse oximeters and always tracking the oxygen levels in every COVID patient. In COVID, risk of hospitalization is more. Oxygen support needed will be more. It's important to give thromboprophylaxis for anybody who is admitted in the hospital for COVID. If there is no definitely contraindication, they use sometimes steroids if indicated to decrease the inflammatory reaction, and some antivirals can be used. So my question is, and this is very important, antibiotics are used to treat influenza and COVID in pregnancy, and most of the people say definitely no. Yes, I know it's no, because antibiotics does not treat viral infection, but surprisingly, we found many of our colleagues still prescribing antibiotics for any pregnant woman, or actually non-pregnant, if they have just a common cold, and this is very surprising. You don't prescribe antibiotics for COVID, you don't prescribe it for influenza, except if you are suspecting a secondary infection. And actually suspecting secondary infection sometimes is out of your scope as obstetrician. Because if the pregnant woman start to have like a pneumonia, like colored sputum, sometimes you need to refer to a colleague with like a chest doctor or something like that to prescribe antibiotics, but just don't prescribe it, because actually this is cause more harm. It's creating antibiotic resistance and may affect the fetus, because even the very common antibiotics we are prescribing and saying it is safe, it's not 100%, still there are risks from them. So don't abuse them and write antibiotics for every woman who having a viral infection. So final recommendation, influenza, as I said, we should advise every pregnant woman for annual vaccination for influenza and vaccine if there is a national vaccination program for this, and follow definitely the national protocols. All the available data did not indicate any safety concerns on pregnancy or any safety concerns on the fetus from taking the vaccine during breastfeeding or during pregnancy. Influenza vaccine can be taken during any trimester, and as I'm saying, it's mostly recommending during before the start of winter, so in September, October are generally good times, because this is the peak of infection throughout the year, and can be considered at any time during pregnancy. So lastly, what's the message? Pregnancy increased risk of severe illness from influenza and COVID-19. You should be aware of this and don't take the complaint of a patient saying I'm having like dyspnea or something in my breast after what you're calling influenza or just a common cold, because maybe she's having something more serious. Both infection have a high rates of preterm labor and complication, and we'd advise vaccine for both infections, and early diagnosis and treatment definitely improve the outcomes. And thank you. I would like to present Professor Dr. Yasser for the next lecture, and it will be Professor Dr. Yasser.
Okay, that's fine. So,
Dr. Yasser, can you hear me?
yes, sure. Can you hear me now?
Yes.
Okay, that's fine. So just before we start, Mariam, do we have any question to Professor Sameh?
No, doctor. Currently, we don't have any questions.
Okay, thank
So, Sameh, thank you very much for your wonderful presentation. However, if we wanted to have debriefing or just bullets, straightforward bullets, that you would like, or you would like to advise everyone to do? Okay,
As I'm saying
what your
in the
recommendation?
first visit I'm sorry?
So if you want to put certain bullets
Mhm.
for any case pregnant now, whatever her gestational age, with high fever and manifestation of influenza or common cold, what do you recommend? What can we do?
Just supportive treatment. You take antipyretics, you take fluids, you take some rest. But as I'm saying, if you have a continuous fever and started to develop secondary symptoms like dyspnea, for example, sputum, okay, symptoms bronchitis, you need to go to another consult. It's not an obstetrician in this way. You shouldn't try giving just an empiric medication in this case. She should be referred to chest doctor or whoever the doctor she needs to be seen to give a proper antibiotic. And for myself, to be honest, Dr. Yasser, I'm always have a very threshold to refer pregnant women if they complain of unusual symptoms.
That's great. And what about vaccination?
They are safe. I mean, all the data available are saying it's safe. And I'm
When do
advising
you
all
recommend
pregnant
them?
women. I'm sorry?
When can we refer pregnant ladies to have vaccination?
I mean, for the influenza, it's present everywhere. On the private sector and in the governmental hospitals, it is present everywhere. Considering the COVID, it's not in the private sector, but they can go to the Ministry of Health. And I mean, they have like a program for vaccination, and they can advise you about the doses and the order of doses. But influenza vaccine is present in many places.
So do you recommend patients or pregnant ladies to have vaccines during their pregnancy?
Yes, sure.
And when is that?
I mean, for the flu vaccine or influenza vaccine, I'm telling every pregnant woman in the first, visiting pregnancy, please try to take the flu vaccine because it's very important for you in pregnancy to decrease the symptoms, especially as I'm saying before the winter in September and October. Please try to take this vaccine. But for the COVID vaccine, actually, I mean, it's different types of vaccines with different regimens. So they should be referred, I mean, to the Ministry of Health clinics, and they can tailor the treatment or actually the vaccine schedule for them.
But it's safe.
Yes, yes, yes. All the available data saying that they're safe.
Pregnancy.
I didn't find any paper saying there is a problem with those kind of vaccines. I mean, many doctors are just afraid of prescribing vaccines for pregnant women, but you should, I mean, balance between the risk and the benefit. So, for example, if you have a bite from a dog, it is very important to take a rabies vaccine. Don't say it could cause, because actual rabies are fatal. So you should have the knowledge of knowing what are the safe vaccines you can give during pregnancy. And most of the vaccines given to the respiratory disease are safe in pregnancy.
That's great. So during antenatal care, you will advise every lady, pregnant lady, to have flu vaccine. That's
Yes,
number
sure.
one. But if any one of them is going to risky places, for example, China, crowded places or something like that with rescue for COVID, you will advise them to go straight ahead to the ministry or to the National Health Services to have this vaccine, which is completely safe.
Yes,
right?
and try to advise them not to be, I mean, in too much crowded places. I'm always telling like this.
That's great.
I mean,
that's great. Thank you very much. It's wonderful. So it's straightforward to the point. So you recommend it to, this is new for me, just to recommend flu vaccine for every lady, pregnant lady with the beginning of pregnancy, even if she come during the mid-pregnancy, I will advise her to have this flu vaccine. Meanwhile,
the only
if
thing
she's
is, I just need to mention about this vaccine. And if you are allergic to eggs, and this is quite common, you should
yes,
ask the health care, because it could be allergic for you to have this vaccine.
that's fine. Thank you very much. Thank you.
Thank you, Dr.
I'm
Yasser.
appreciating your clinical application and to be direct to the point and your advice. And instead of have didactic lecture, it's just how to use and what to do and how to be useful for everyone. Thank you very much, Sameh. Any other
Thank you,
question? Mariam? Mariam?
There's only one question.
Mhm.
Two questions. Professor Sameh, any role of delivery in cases of COVID or influenza and severe cases, of course?
No, I mean, you never take a decision to deliver a patient with COVID or influenza if other doctors, as I'm saying, it's not you as obstetrician saying it is a life-threatening thing to have this pregnancy, or you need to deliver this baby because we need to give like a life support or CPR or something like this. But you don't take this, action. It doesn't make any difference, except, it's not your decision as obstetrician, except in case if you have a fetal distress or something like that. But this is not an indication, definitely.
Okay, there's another question. Which type of COVID vaccine is more recommended? Because many ladies in Egypt are afraid from certain companies.
Honestly, most of the research are published on all types of vaccines. I didn't have any, or I didn't encounter any research saying this type of vaccine is not recommended during pregnancy. They are just talking about the corona vaccine, and they're saying all of them are safe. So it's not 1/1. It's not like this. So whatever is available, you can just take it.
Are there any special considerations for prophylaxis in COVID positive pregnant ladies or patients?
This is a quite tricky question, but definitely if you have a COVID patient admitted to the hospital and she is, I wouldn't say bedridden means she's on a ventilator, but she's in a hospital staying on a bed, you need to think about thromboprophylaxis. But if she's nowadays, if she's just pregnant, you need to actually record her VTE risk and see if she needs or not, but it's not by default, you have COVID, I need to give you a thromboprophylaxis. It's not like this. But again, those cases should be treated with you and the internist, or infectious disease doctor. It shouldn't be you alone by yourself. You should take the opinion of other doctors.
Okay, the last question. Any role for Doppler for fetal assessment in COVID?
I'm not the best one to answer this question. I'm not specialized in ultrasound, but as I say, the paper we published 3 years ago, we didn't find any changes, considering the growth or the Doppler studies on fetuses. But again, it was a small study. So I cannot say I can recommend doing this. I'm not sure about the validity of such, I would say, an expensive test for every pregnant woman who is having COVID. But my thinking, I don't think they need to do like this. If the baby is moving well and everything is fine, why she should? Maybe Dr. Yas has another opinion. I don't know.
No.
What do you think, Dr. Yas?
There is no definite relation between this and that, and you cannot guarantee that we have congenital abnormality by the effect of influenza vaccine, or apart from just some papers said that it might have an effect on the cardiac, on the heart of the baby. Is it right or wrong? We don't know, actually. But high fever might be associated with preterm labor. And
Yes.
as well, viremia might be associated with growth retardation and fetal distress as well. But congenital abnormality, as far as I know, there is nothing to do.
No,
Just follow up.
he's asking if a pregnant woman has COVID, should we refer her to have a Doppler studies? I'm not
No.
quite sure, because there is no clear recommendation saying you should. But definitely, if you're following this patient and you found IGR, for example, definitely you refer her for a Doppler. But as an immediate action, I don't think.
Okay, Doppler has nothing to do with initial management of cases, but Doppler is a secondary way of assessment of the cause of growth retardation, okay, or a defect in the movement. So it's not an initial instance for something. So if you have hypertension, you might do Doppler. If you have diabetes, you might do Doppler. If you have growth retardation, you might do Doppler. But Doppler is not an initial one. It's complementary, complementary just to check the blood flow to the baby, and that's it. If it's the cause of the problem or not. Okay.
Okay, you may start, Professor Yasser.
Okay.
Thank you, Dr.
Okay.
Dr. Sameh.
Okay. Shall we start?
Thank you.
Yes.
Thank you very much, Sameh. It's wonderful, to be honest. It's great. Thank you very much.
Thank you for that.
Viral hepatitis is one of the most important and the most dangerous problem that might affect pregnancy and pregnant ladies as well, especially in third world countries. So what I'm going to discuss now The first part will be what does it mean, hepatitis? And based on the pathophysiological changes, what will be the presentation and how can we detect it? And its acute effect and remote effect as well.
Can
Okay,
you
that's number one.
put it on full screen, please?
I'm sorry?
Can you put your screen on full screen?
Full screen.
Or the slideshow show. Yes, thank you.
Okay, that's fine. So, the first thing I will explain what's hepatitis and its effect and the and the presentation. Second, we will discuss the commonest cause of hepatitis during pregnancy or outside pregnancy, which is viral hepatitis A, B, C, and D. And how can we manage according to the new recommendation and the international recommendation of the different guidelines. And lastly, we will have general recommendation. If you have a pregnant lady, how can you protect her from having hepatitis? If she has a sort of hepatitis and she is pregnant now, what to do? Just to be practical session. Okay, so let's go first. What's hepatitis? Hepatitis means inflammation in the liver. As we see here, the liver is composed of two things. Liver cells, which is called hepatic cells, which is arranged in rows. Between each group of different cells, there is tunnels, which will receive secretion coming from these hepatic cells. This is the liver. The liver is supported with high vascular tray, which is called portal circulation and hepatic circulation as well. This is the liver, and very simply like that. So what hepatitis means? Inflammation of the hepatic cells and in the duct system as well. What is the effect of that? Hepatic cells have three functions, main three functions. One of them is to come over the destroyed red blood cells. So every 90 years or every 90 days, the red blood cells will be destroyed, producing heme and globin. The globin will be protein absorbed in the circulation. Meanwhile, the heme will be changed to bilirubin. How can we do that? It will be catched by the hepatic cells, changed in the hepatic cells to bilirubin. This bilirubin will be secreted because it's toxic. It will be secreted in the bile ducts to go through the bile ducts to be secreted in the duodenum to change to what's called bile acids. This bile acids is called stercobilinogen. This stercobilinogen will pass to the stools, causing coloration of the stools to dark color, which is brown. Meanwhile, some of this bilirubin will pass to the circulation of the blood, the vascularity of the liver, to pass as another type of salts of the bilirubin. It's called urobilinogen, which will pass to the kidney and pass to the urine, cause discoloration or sort of coloration, yellow coloration of the urine. That's why we can come over bilirubin. If anything happened to these liver cells, bilirubin will be accumulated in the blood and as well in the liver to pass to the blood. What's about its effects? This bilirubin, if it's increased, it will be accumulated under the skin, cause discoloration of the skin and yellowish formation or yellowish discoloration of the skin, which will cause marked irritability and itching in every part in the body, affecting the social life to the extent that the one cannot walk outside because he is itching or she is itching 24/7. As well, the color of the skin will change it to become yellow, especially in white area like sclera. Is that all? No. There is another problem. If it's bulged in or just secreted in huge amount in the blood, it will pass to affect every organ. But the most important one, it can cross the brain barrier to the brain. And this is highly irritant to the brain, cause some sort of irritation to the brain. It's called encephalopathy, which might cause some sort of irritation and cause behavior change of the person to the extent he can do something which is very strange. You might have a minister and standing without clothes and crying in the balcony. So it will cause some sort of encephalopathy and disorientation to everything. So this is bilirubin. So it's a very dangerous thing. Okay. So this is because of hepatitis or destruction of the hepatic cells. This is the main function of the hepatic cells. If we have some sort of destruction of these cells, so the enzymes inside these cells will bulge in the circulation. That's why the liver enzymes will increase, which indicate destruction of liver cells. And bilirubin as well will be difficult to come over. So it will bulge in the circulation, cause this yellowish discoloration and itching. If that's all, no, hepatic cells as well is responsible for production of albumin. If it is destroyed, so albumin will be markedly reduced. As a result of that, the total protein in the circulation or in the blood will be markedly reduced. The osmolarity of the blood reduced. So the water will be transmitted from the circulation to the spaces of the body, especially in the abdomen, cause ascites and marked swelling of the abdomen and generalized anasarca or generalized swelling all over the body. So you will have jaundice, itching, encephalopathy, ascites, pleural effusion, and marked generalized anasarca. Is that all? Another thing as well. The liver cells, that's responsible for protein production. It will produce a very important protein substance responsible for coagulation formation. So if these liver cells destroyed, it will be hell. Why? Because coagulation factor will never be done. So in association with all these manifestations, which will be presented as symptoms and signs and investigations as well in the form of increase the bilirubin, direct and indirect, and liver enzymes as well, coagulation factor will not be done. So there will be prolongation in the clotting factors, clotting time, and increase the bleeding time as well, and coagulopathy. And it's a hell. Is that all? This is for liver cells. So if we have destruction of the liver cells, it will end up by increase the bilirubin, coagulopathy, and generalized anasarca and ascites. If we add to that liver cells, in between these liver cells, there is ducts. These ducts enrolled or aligned by special type of cells. As a result of swelling of these hepatic cells from inflammation, it will pass by 2 stages. It will squeeze this duct system, and because of its swelling, and this duct system will be obstructed. As a result of that, the bilirubin that's created by hepatic cells and pass to this duct system will increase. And because of obstruction, it will bulge in the circulation, cause marked increase in the bilirubin. So the bilirubin, which will increase in the circulation, will be 2 types. One type is created in the liver cells, which is not attached to any proteins in the circulation. So it could be detected by direct immunoglobulin. It's called direct bilirubin. And as well, because of the red blood cells that is destroyed and cause hemoglobin, and the heme will change to protein, to bilirubin. This bilirubin will be attached to albumin and other proteins. So it could be detected indirectly by using antibodies. That's why both the bilirubin type, direct and indirect, will be markedly increased. Liver cells will be increased, which is SGOT, SGPT, and alkaline phosphatase as well, which is inside the liver cells because of its swelling and rupture, after which will increase with all these manifestations. Is that all? No, it's a hell. Because if pregnancy occurs, the risk of fulminant hepatitis will occur. What does it mean, fulminant hepatitis? It's market destruction because liver had the capability to repair itself by itself. Even if you have 10 to 20% of the liver cells that are there, they will be replicated and increase again, and it can compensate. On liver transplant, we transplant just a small size of hepatic cells and it will regenerate. Meanwhile, fulminant hepatitis means that all the liver cells will be destroyed and all this manifestation will appear and it might end by death. If we know that special type of hepatitis might be associated with hepatic cancer. Why? Because of destruction of these cells will be followed by repair. Destruction and repair, which cause some sort of immunological disturbances, which might be associated with hepatoma or cancer liver. This is the sad story of hepatitis. And now the question is, what are the causes of hepatitis? Causes of hepatitis are lots and lots of causes. It could be congenital, could be traumatic after car accident, for example, or playing karate or football or something like that, or inflammatory, or neoplastic because of malignancy over hepatoma. Inflammatory, you have lots and lots of organisms that might circulate in circulation, go for hepatic cells, cause marked inflammation and destruction. Cytomegalovirus might be there, influenza virus might be there, COVID might be there, toxoplasma might be there, and lots of things. However, the most dangerous and the most common one, it's hepatitis virus type A, B, C, D, and E. Why? Because all of these viruses are widely spread all over the world, especially in third world country and in Asian countries. In Egypt, it's highly spread. Why? Because it's associated with a big national problem in Egypt. It's called bilharziasis. Okay? So it's global wise. We can say that 350 million people all over the world has chronic hepatitis B virus. What's chronic hepatitis B virus? Sooner or later, they will die of what we said before. And what about hepatitis? A little bit. It's 58. However, the problem with hepatitis C virus, it's very common to be associated with cancer. Cancer liver. So it's big. It's a big problem. Why it's widely spread all over the world? It's because simply the mode of transmission is very common. It's sexually transmitted, it's blood transfusion, mainly through blood transfusion. So car accident, operative intervention, cesarean section before, placenta accreta, anyone or any woman has blood transfusion is at risk for hepatitis. That's number one. Number two, anyone used to have medication for chronic disease using needles are great risk for hepatitis. If we add that, sexuality might be associated with hepatitis. Why? Because during introduction of the male genitalia in the female genitalia, we might have minor abrasion at the crown of the male and abrasion as well to the vagina. And minute blood will pass from here and there and might end by hepatitis as well, especially in hepatitis B, but not C. So any lady has blood transfusion, has operative intervention, has hepatitis before, has jaundice before, and as well, she's multiple sexual partners, and her husband has hepatitis, all of them are great risk for hepatitis, whatever the type is. The problem not with the lady only, but if she has hepatitis and pregnancy, this hepatitis might cause increase in the temperature and viremia, which might be associated with preterm birth, low birth weight, and intrauterine fetal death. However, one of the most important things, especially in B and C, ascending infection, vertical transmission of the organism from the mother to the baby, okay, which will carry the risk of neonatal hepatitis, which will end by chronic hepatitis for this baby since he's born. So our objective from what we are going to tell is to reduce vertical transmission. If you have a lady with hepatitis, so try to reduce vertical transmission to the baby. So we need a policy to detect presence of hepatitis in this lady during pregnancy, either if she has manifestation or not. And if it's said, try to do by all means all the measures to prevent vertical transmission. That's number one. Number two, to optimize the maternal health to avoid as much as you can the complication of the disease during pregnancy. This is for the lady. And what's about the baby? Because of there is risk of transmission of the virus to the baby, so we are trying by all means to have some sort of prophylaxis as early as we can to prevent this the effect of this virus on the baby. Let's go step by step. So for virus hepatitis, what to do? Risky people that you are going to ask for are people with partner hepatitis, past history of hepatitis, blood transfusion, if she has operative intervention. So you have to screen all of them with the antenatal care. Okay, how to screen of them? To have hepatitis B surface antigen testing. Straight ahead, if it's positive, so you have to do E antigen. Why? Hepatitis B surface antigen means that the lady has the infection, but is it infectious or not? So this will rely upon the presence of hepatitis B E antigen. If E antigen is positive, means that the lady is infectious. And if it's infectious, so the vertical transmission, especially for hepatitis B virus, will reach to up to 90%. What does it mean? That every 100 lady with hepatitis B virus surface antigen positive and the E antigen positive, 90 will be transmitted to the baby. So this will rely upon the viral load. That's why if you have hepatitis B surface antigen testing positive and the E antigen positive, you have to do straight ahead detect the virus load, which is DNA to determine the virus load. It's PCR, polymerase chain reaction to detect the virus load. If the viral load for this lady is 200,000 international unit per milliliter, especially in the third trimester, so it's very, very, very risky to transmit this problem to the baby. So what to do? You have to give to this lady during the third trimester, during the antenatal period, the treatment. Okay? And what's the treatment? It will be 300 milligram tablet every day till postpartum period is tenofovir. Okay? When to start? As early as possible from the 7th month of pregnancy or the 8th month, between 28 and 32 weeks of pregnancy, to start to give her this medication. And when to stop? After delivery by 3 months. Straight ahead. Once the baby is delivered, okay, so by this medication, you reduce as much as you can of the viral load, and you are trying to reduce the transmission of the virus, which is 90% to 20 to 30%. Once the baby is delivered, during the first 12 hours, you will give the baby two things. You will give immunoglobulin, which is blocking, neutralizing the as much as you can, and as well you are going to vaccinate the baby against virus hepatitis to produce antibody against virus to allow after that breastfeeding. Okay, so after that breastfeeding will be safe if infant vaccinated. So it's crystal clear. This is the 24 guideline and bullets which is updated with 23rd of the year 23. Okay, so it's straight guideline even by WHO and by the EASL. Okay, risky people screen hepatitis B surface antigen, positive E antigen. If it's positive, PCR. If it's more than 200, straight ahead give tenofovir 300 milligram every day, starting from the 7th or 8th months till 3 months after delivery every day. When the baby delivered, give the baby immunoglobulin during the first 12 hours, followed by vaccination, and allow breastfeeding. What about hepatitis C virus? Transmission of hepatitis C virus is less. If we said that it's 90% in B virus, it's 5 to 10% in C virus. Usually C virus, it's asymptomatic. This is the problem. Meanwhile, hepatitis B virus, it's symptomatic in the form of jaundice, itching, change in the color as the stool, the urine, and so on. But the problem comes with hepatitis C virus, which is usually asymptomatic. That's why it's the recommendation to screen for hepatitis B and hepatitis C virus in all risky people, especially if they are not symptomatic. So the recommendation is to screen when at the first pre-antenatal visit. How? Screening by hepatitis core antibodies. If it's positive, you have to check if this lady is infectious or not by, again, PCR for RNA. If it's infectious, this is the problem actually, because it's highly infectious one. So what we are going to do, we are not going to, it's not approved that we are going to give any medication like Sovaldi or something like that. It's not approved. It's not only that, it might be contraindicated as well. But what we are going to do, we are afraid of fulminant hepatitis to the lady because vertical transmission is very low. So what we do, it's monitor of progress of the disease every month or every 2 months. We have to monitor the liver enzymes and avoid during pregnancy invasive procedures, especially for the baby, like fetal scalp monitor. It's completely to avoid transmission to the baby. Meanwhile, spontaneous transmission will be only 5%. And counsel on postpartum hepatitis C virus treatment in after delivery. This is the CDC recommendation. The vertical transmission, as I said, it's very low. And breastfeeding is safe unless liver cracking and nipple is cracked. So what we do, you can breastfeed the baby using nipple shield, which is completely safe for the baby, okay, to avoid transmission of blood to the baby. Why that? Because the transmission is 5%, it's low, and there is no vaccination for hepatitis or medication we can do, but it just only screen and follow. What about hepatitis E virus? Actually, it's not in our country. It's mainly in Asia and other area of Africa. The point is, it's very dangerous because once it's there, no alarm, but it will cause market destruction of the liver in no time in pregnancy. The mortality is high, might be 1/4 of the ladies with pregnancy during pregnancy. And how it's transmitted, it's by fecal-oral transmission using raw water or uncooked meat. So try as much as you can to change behavior of eating and supply people with healthy water. So prevention by hygiene, avoid uncooked food. I remember well that every lady come to me. I used to tell her you can take liver twice weekly. You can take fish and its product twice weekly. Okay, but for example, the raw meat, it's called basturma. I used to tell them avoid taking them because it's raw meat. If you want to take it, you have to be cooked. However, we have actually vaccine against hepatitis E, which is in the Far East in China. However, it's not recommended for every case. But what can we do if we have it? It's just supportive management and avoid spread of this problem. And let's have the least one. It's hepatitis A and hepatitis D. For hepatitis E, it's by eating, and it's very common to cause gastroenteritis in the cats and in the ladies as well. Rarely to be severe, and it's self-limiting. Okay, it's highly risk, and just to avoid its symptomatic treatment. What's about D? It's the point is hepatitis B virus co-infection might be associated with D, both of them. So the treatment to avoid D is monitor for flare and optimize support of the hepatitis V. Ladies and gentlemen, let's have a sort of guideline of what we do to avoid this problem. Preconceptional, try to avoid bad water and to have hygiene. To be vaccinated against hepatitis B and hepatitis C. Try to avoid as much as you can drugs that might destroy the liver, such as acetaminophen. Vaccination against hepatitis A and B, and as well try to have some sort of treatment pre-pregnancy for hepatitis B and hepatitis C. During antenatal care, it's crystal clear. Screen all pregnant women for history. When you have, like you ask for blood group and RH, CBC, random sugar, TSH, you have to screen for hepatitis B virus and hepatitis C as well. If you have a viral load with hepatitis B viral, so try to give the medication 300 milligram in the 3rd trimester. Meanwhile, defer the treatment with the medication against hepatitis C, because the medication against RNA virus in cases of hepatitis C might have a toxic effect on the baby, so defer till after delivery. Multidisciplinary care, and no one can deny that. Vaccination in high seronegative patient is very important, and put in your mind that vaccination for hepatitis B and C are safe because it's particles of the virus, not living attenuated or living viruses. And monitor if you have hepatitis patient and pregnant, so you have to ask for the albumin, liver enzymes, and bilirubin, direct and indirect, every trimester. During delivery, cesarean section is not recommended as a routine, but individualized according to the situation. But one of the most important thing, try to avoid prolonged rupture membrane. So give her just 1 or 2 hours and deliver her. Even you have to deliver her by cesarean section or instrumental delivery. We wouldn't prefer to have instrumental delivery because it might be associated with vertical transmission. But the most important thing, try to avoid needle or monitor or internal monitor or internal CTG for the lady using needles to the baby's head, because, or fetal blood sampling, because this will cause a problem with transmission of this virus to the baby. And postpartum, what to do? Ensure neonatal hepatitis B vaccine and hepatitis B immunoglobulin. If you have hepatitis B, resume antivirals if indicated, and hepatitis C, start medication straight away. So, ladies and gentlemen, in conclusion, early detection and prevention strategy are key. Never ever to forget to screen for hepatitis B and C mainly for antenatal care and to consider them as very important. Hepatitis B virus, give antiviral medication and neonatal prophylaxis. And don't forget to have hepatitis B surface antigen. If it's positive, E antigen. If it's positive, it means it's infectious. So you have to screen by PCR to detect the titer. If it's more than 200,000, you have to give medication to decrease the viral load. And once delivered, because vertical transmission is still there, you have to give during the first 12 hours immunoglobulins followed by vaccination. And what's about hepatitis C and E management? Postpone the management till after delivery. Multidisciplinary care are recommended. So, ladies and gentlemen, thank you very much. And this is just summary to what I said, that I will leave it. Okay. So, as you said, hepatitis A vaccination might be there. Hepatitis B vaccination might be there, and the treatment during pregnancy. Hepatitis C, no vaccination, but treatment. And thank you very much. If you want to have any question, I will be more than happy.
Thank you, dear Professor. There's one question Dr. Wafa is asking. What will happen if breastfeeding gets infection? Should we hold breastfeeding, or can we collect breast milk and give it to the baby?
The point is, milk is not infectious status. Milk is clean. But the point is the blood. Again, transmission of hepatitis B or C will be through the blood. So during intercourse, despite the fact there is no blood, but minute abrasion between the genitalia of the man and woman, which is not seen, is the source of infection. And what's about breastfeeding? The baby usually squeeze the nipples of the lady, cause some sort of trauma. So bleeding will occur. If bleeding occur and minute abrasion to the mouth of the baby, this will cause blood transmission. So the milk is safe, no problem at all. Okay, the point is try to avoid any blood come from the nipple of the baby. How? Using breast shield, which is just plastic material used to be put on the nipple and the areola. Or, as you said, but the point is, if you have suction machine, this might have some sort of trauma to the nipple and might cause some sort of blood coming with the milk. So I wouldn't prefer to collect milk, but to have what's called milk shield, breast shield. But the milk is not sort of infection.
There is another question from Dr. Amel. I wish to ask about immunoglobulin for fetus delivered to HBsAg positive, regardless the E antigen testing, or only for the E antigen positive only.
Let me just to conclude it just in one or two words. If you have hepatitis B surface antigen positive, it means that the lady got infected before. If you have hepatitis B surface antibody, so she is cured now. If you have hepatitis B surface antigen positive, so we have to check if she's still infectious or cured. So we have to do hepatitis B E antigen. If E antigen is positive, means it's highly infectious. Okay, so in this case, we have to check the viral load. If the viral load is high, more than 200,000 international units, this is the time which we give immunoglobulin and as well vaccination as well.
Okay, if a patient decided not to breastfeed, could we transfer to hepatologist to modify management plan or continue on tenofovir 300 milligrams?
This is not under our supervision, by the way. This is, as I said, multidisciplinary team. So from the beginning, during the antenatal period, we refer her to a hepatologist just to check that everything is right. Okay, and we will have shared care between hepatologist, gynecologist, me, and neonatologist as well. So we are telling the incubator that this baby, his mother is hepatitis B infectious one. So just prepare everything. And as well, during the antenatal period, we refer her to the hepatologist and postpartum as well to continue medication.
Okay, the last question, Professor. In cases of HBV and HDV co-infection during pregnancy, is there any rule for off-label use of interferon postpartum to reduce significant liver damage?
As far as I know, I don't know interferon, is it efficient or not for HBV or for HIV or whatever. It's not my business actually, and I'm not sure. But what I said, I'm sure of it. This is according to the guideline. But interferon, is it efficient or not in this case, and the dose as well, I don't know.
Okay, thank you so much.
Any more questions?
No, thank you.
Thank you, Professor Dr. Esser, for this marvelous presentation. It covered everything, actually. I want to present my dear friend, Professor Dr. Muhammad Hassan. He is a consultant of gynecology, a board member of the Egyptian Representative Committee of the Royal College, and a member of the Royal College. He will talk about HIV in pregnancy. Dr. Muhammad, would you carry on, please?
Yes, thank you, Professor Yasser Abu Taleb, for this wonderful presentation, and thanks, Professor Sameh, for the lovely words. I'm very happy to be with all of our candidates and friends in this room. I'm going to talk about the HIV in pregnancy, and I'm afraid that many candidates are not familiar with HIV because some of them are considering that this is a very rare condition to be handled in our patients in MENA region, by the way. But unfortunately, I think it's the numbers of cases started to be increased, and then we need to know at least the basics of the management, the diagnosis, and the risks of transmission from the mother to the baby, and how to manage a woman and her baby immediately after delivery and during delivery as well. So let's start. I promise it will be a very targeted session. The HIV, updated our knowledge from the Behavior Guidelines 2025. So most of information will be from there. The nature of the HIV, as of all of you know, that it's from retroviruses family. They are RNA viruses. That's why most probably we cannot develop yet a vaccine. Again, it's because the RNA families in virology are very difficult to be managed by vaccines, not like the DNA viruses. Anyway, the retroviruses, from the name retro, means hidden. So the virus main action of power is he can be steady and hidden in the body until the moment when the immune system started to be, not that powerful. The virus will start to attack the body and destroy the immune system. And this is the game. So it's also known as the acquired immunodeficiency syndrome or disease, which is widely known as AIDS. So the prevalence in UK, because the guidelines from UK, seems to be not that much. 0.04% to 0.5%. But actually, let's explain a very important fact, that the disease is more prevalent in central large cities compared to the side ways and other small towns. Why? Because of the culture, maybe? As if all of you know that the HIV is famously a blood-borne disease and can be transmitted through sexual acts, sometimes from syringes used with addict people, and sometimes for paramedical personnel because of the blood contact. So because of all of this, and because of traditional and behavioral backgrounds, the cities suffers more from AIDS, while other small towns here and there, maybe the percentage is less. The second point is, which is really respectable, the diagnosis method and the rate of screening methods in large cities compared to small cities. That's why maybe the prevalence in cities, large cities, is more. Of course, we suffered a lot for many, many years in Africa with the HIV. And I remember in 1998, 97, the South Africa as a country was counted like the most common country in Africa with HIV infection rates. It was really a horrible experience previously. And so on, we can compare sub-Saharan African to the South Africa as well. Fortunately, over than 88% of HIV infected pregnant women are diagnosed prior to delivery. Thanks God, and thanks for the guidelines which obliged the medical team staff to screen for HIV to any pregnant lady coming to the A&E. All pregnant women should be offered HIV testing at booking visit in early pregnancy and in every pregnancy. And the test should be sometimes repeated one more time around 28 weeks, especially with high risk group of patients. What is meant by that? People who are at higher risk to catch the infection than others. We can summarize some of them, like the teenagers and multiple sexual partners, women, the addicts and homeless patients, sometimes in other countries with immigrants and victims of domestic violence, and of course the sex workers in the industry, and paramedical and medical personnel. Poor of us, because we are daily exposed to blood and blood products. By the way, the routine repeated testing to identify the small number of women who may be seroconverted during pregnancy is not recommended. What does that mean with seroconversion? This is what we are going to explain in few minutes. Let's say that simply the HIV tests was depending on detection of anti-HIV antibodies in blood, which is very logic. The immune system, despite it's been attacked by the virus, he's still able to production of antibodies against the HIV. These antibodies are diagnostic. But the problem is there is a delayed response between the time of infection and the immune antibody response. It's maybe 36 months, 3 years. So the patient may carry the infection and nobody can confirm the diagnosis. This is known very well as the window phase or the window period, when the patient is spreading the disease and nobody knows that he is a carrier. For that reason, the new technique of the investigation tests, which is mainly detecting a protein B24 antigen, which is released by the virus, helped to minimize the window period to almost 1 month instead of 36 months. And fortunately, it was really good news that we can do the test either from a blood sample or from a saliva or other body fluids, less commonly the urine. Okay, so this is regarding the tests. And the rapid test is available with good results and highly sensitive results, more than 95% accuracy within 20 minutes. So I think it's very necessary that all healthcare providers and healthcare units should provide such tests available, especially for emergency cases and women whom are unknown status regarding the HIV. Okay, that's fine. So what is next? Don't forget, if the patient is high risk for HIV, she's also definitely high risk for other sexually transmitted infections. Am I right? So if the patient is high risk for HIV, she is still high risk for HBV and HCV, because all of them share the same mode of transmission, the blood-borne diseases. And still, because the HIV is also a sexually transmitted disease, so the patients are at higher risk of chlamydia infection, gonorrhea infection, syphilis, and maybe other sexually transmitted infections. So preferably, if the patient is in a high risk zone for HIV, offer her screening for other blood-borne diseases as well as the sexually transmitted infections with swabs. Now, if you have a case with an HIV patient, she is pregnant, like not right now, and she is either newly discovered case or well-known HIV positive case, and she's pregnant, are you going to give her any immunization? Of course, we have to think about immunization because the patient is immune compromised. Even if the HIV is very early stage, but she's still immune compromised by the effect of pregnancy itself. So it's preferable to offer the patient inactivated, of course, or killed vaccines, influenza and pneumococcal vaccines. They are highly protective and routinely given to all women in such situation. And recently in 2025, the BHIVA highly recommending using of respiratory syncytial virus vaccination and should be offered to all pregnant women from 28 weeks of gestation up to the delivery time. It's not only protective for the pregnant woman with HIV, but it's also protective to pregnant ladies overall, and the protection is transmitted to the baby as well. And it's really helpful to minimize the neonatal morbidity and mortality later on. And then how all pregnant women with HIV also should be offered seasonal booster doses of COVID vaccination. And because I hear to the questions in the room, I can't prefer one type of COVID vaccinations over the other one. Of course, the live attenuated vaccines definitely are contraindicated in pregnancy, either with HIV or without HIV, because the immune system by pregnancy itself is really declined. Now, to understand more the course of the disease, let's ask a question. If I said to anyone in this room, we are more than 300, mashallah. If I asked anyone in the room, if I told you a patient with HIV and she's pregnant, what is the first thing coming to your mind? Viral load. We need to detect the viral load. we will put our plan on the viral load, depending on viral load. Actually, the viral load is very critical and important issue, but the CD4 count is equally important in evaluation and putting a plan of management towards the HIV patient in pregnancy. For example, I need to explain what is meant by viral load. It means the ability of the virus to replicate himself. And this is equivalent to the infectivity power of the virus. So what is meant by CD4? CD4 are a protective cells produced by the immune system. So if there is a significant decrease in CD4, it means that the immune system is going to be collapsed. Is that changing my mind towards the management? Yes. If I have a problem with viral load and the viral load is markedly increased, I will offer the patient antiviral treatment to control the replication and infectivity of the virus. But if I have a moderate or even high viral load, but the CD4 are markedly declined, it means that antiviral treatment should be secondary option because this woman will die very soon because of the lack of immunity, opportunistic infections, very weak infections, commensals, all of them will collaborate together to raise up infection and sepsis because there is no immunity. CD4 should be managed first, even with high viral load. So take care of that. Sometimes, you may have a scenario with a woman, she's HIV positive, and the viral load is 10,000 per milli. Wow, this is a huge number for HIV. And the CD4 is 100. Oh, it's never should be below 350. What should you do for the patient? Give her antiviral retroviral treatment. I'm sorry. I will give her first prophylactic antifungal antibiotics. This is the priority because the viral treatment will need more time to control the replication, so the patient will pass away. So take care of understanding the mechanism and the balance between the viral load and the CD4 protection load as well. What about the vertical transmission of HIV? Of course, the HIV is transmitted to the baby. It's not a teratogenic infection. It's not like toxoplasmosis, like CMV. It's just transmitted to the baby. No significant ultrasound finding during pregnancy. And in developing countries previously, the rate of transmission is 25 to 40%. What a crime that a baby just facing the world, he will start his life with HIV positive results. Okay. And this percent is much less, 15 to 20% in developed countries. But after implementation of few steps, very simple steps, the risk of transmission is markedly regressed to be maybe less than 1%. Oh, that's great. How can we do that? How can we achieve less than 1% risk of transmission? Give the patient high active antiretroviral therapy, heart treatment. Do a cesarean section because 80% of vertical transmission occurs around the time of labor and delivery. So please go for a cesarean section. And don't offer natural breastfeeding. Okay, don't offer natural breastfeeding. Formula milk is fine if you can afford it. Okay, by implementation of these 3 steps, we can guarantee that the risk of transmission is less than 1% from the infected mother to her baby. Now, we have a lot of options regarding the heart treatment, which are all of them considered safe during pregnancy. However, all heart treatments are associated with a famous side effect in pregnancy. They are increasing the risk of gestational diabetes. So it's preferable to offer a woman checking blood sugar tests regularly, maybe at booking and 28 weeks of gestation if she is regularly taking heart treatment. The second point is heart treatment is a sort of increasing risk of preterm contractions. So if the woman is very restricted to the treatment for her baby's health and her health as well, we should expect that the woman will deliver maximally with 34 weeks of gestation because of the preterm contractions. So these 2 side effects are very famous with heart. Otherwise, there is no significant effect on the mother, on the baby. Now, you don't have to remember all of these treatments, of course, because they are so much sophisticated and not your job indeed. This is the work of multidisciplinary team to manage the case. But I just need you to remember a very important 2 medications. The tenofovir and the lamivudine. Actually, the tenofovir is like a basic first-line treatment for many RNA viruses. And the lamivudine particularly is considered a key medication, especially with HIV and co-infection, because it works with very good with HBV as well, which is common in HIV patients, unfortunately. So you can use any one of them according to the protocol, local hospital protocol or national guidelines protocol, and all of them are considered very safe. So what is the plan of management for a pregnant woman with HIV positive results? Let's say that planned vaginal delivery is always a very valid question by the mother or the woman. Can I deliver my baby vaginally? Yeah, you can. Yes. But you just said that 80% of the viral transmission will be happened intrapartum. Yes, I agree. So that I need to fulfill some important criteria to allow the woman safely to deliver her baby through a vaginal route. So simply, the woman should be regularly on heart treatment all through pregnancy. And the woman test for viral load should show less than 50 copies per milli. These are the criteria. And of course, there is no any co-infection with HIV like HPV or HCV, because the co-infection, even if the viral load is less than 50 copies, the co-infection itself is synergetic effect on the low amount of virus. So if you have 30, 25 copies, oh, this is less than 50. We are in the safe zone. No, if you have an HPV or HCV positive infection, these 25 copies will be more aggressive than 250 copies. The synergetic effect of the co-infection are really important to be considered. So I can offer a woman with these criteria a planned vaginal delivery. Okay, this is very great. Now, what about if the woman viral load is higher than 50, or if she had a co-infection, or she is not taking any heart treatment? Cesarean section electively around 38 weeks should be offered to protect the baby and decrease the risk of transmission. Now, at this point, a very famous key critical medication appeared, which is the zidovudine. Zidovudine is a magical treatment because it works immediate action, and it works mainly to inhibit the activity, temporary inhibition of the activity of the virus. And this is what I'm definitely in need for. If a woman is going to not taking any heart treatment, and I'm going to do a planned elective cesarean section, it's preferable to give this woman zidovudine monotherapy. Yeah, I mean around 4 hours prior to the cesarean section, and stop the medication once the baby and placenta are delivered. These 4 hours will give a very good opportunity for the virus to be suppressed. Now, I can use the zidovudine as well if the woman has a viral load less than 50 copies and she's opted for a vaginal delivery. But because she's not on heart, I can offer zidovudine starting from 36 weeks and thereafter until delivery. So the action of zidovudine is suppression, inhibition of replication of the virus, not to treat the virus, not to kill the virus. It's just a temporary inhibition of the viral activities. Okay. So now the plan, I think, is clear for most of you. How to reduce the risk of transmission. This is what we are talking about. The heart, the elective 38 cesarean section, and prevention of natural breastfeeding. What about the baby? Now the baby is delivered, okay? Again, there is no allowed or licensed medical oral treatment for prophylaxis to the baby rather than the zidovudine if the baby is very high risk to be infected until the results coming back is either positive or negative. And the post-neonatal prophylaxis, PMP, the post-neonatal prophylaxis should be started within 4 hours of delivery, with no benefit demonstrated if it started after 72 hours of delivery. And this is, by the way, most of post-exposure prophylaxis, it should be started as early as possible. Within 72 hours, it has no rule. Recommend immunization for the baby as per national schedule according to your country. There are no contradictions to use live attenuated vaccines like MMR to the baby or PCG to the baby because the immune system is still not that affected. This baby, after taking the prophylaxis, should be closely followed up. I will start the follow-up, the test by the primary testing within 48 weeks, hours after delivery. And then 6 weeks of age of the baby, I will retest him again or her. And I will repeat third time testing 12 weeks after delivery. And the final decision regarding is the baby is positive or negative for HIV should be finalized around the age of 1.5 years. I will repeat the test last time, HIV antibody testing for seroconversion around 18 months after delivery. This is just to confirm if the baby is catching the infection with seroconversion or not. Okay? What about some sophisticated cases? You have a patient that's HIV positive and she called you and she said, I have a broken membranes broken water, and there are some preterm contractions started to develop. How can you manage this case? Actually, if we are less than 34 weeks, we have to take a deep breath and we have to wait and conserve on this patient, starting with tenofovir and a single dose nevirapine, and both of them are highly recommended by the behavior because they are passing the placental membranes, the placental blood barrier in large doses. And this is my aim, is to give the baby a prophylactic doses of antiretroviral treatment. But if this happens with a woman and a baby more than 34 weeks, I will be very happy to deliver her. And it's preferable to establish the delivery less than 4 hours from the broken membranes, because after 4 hours of rupture of membranes, the baby is potentially infected. Okay? So this is rapidly that plan. I think we did it. I tried to be very focused to the point regarding the management of HIV in pregnancy, because the guideline is unbelievable. It's about 300 or 400 papers. So I tried to select the most important things from the practical point of view and the knowledge as well. Thanks so much. If you have any questions, I'm happy to answer.
Thank you, Professor Dr. Muhammad, for this extraordinary talk. You made HIV very easy for us, despite being a very complicated text, really, in obstetrics. Thank you. And if there is any questions, please answer. I think there is a question saying, please simplify neonatal
Is there a
treatment.
chance to get access to previous webinars? Yes, of course. They are available already. Zidovudine is given in elective cesarean section as well. Definitely, Aisha. If a woman is not on heart treatment regularly for her health, either prior to the pregnancy or antenatal period, of course, she should be given suppressive doses of zidovudine prior to the elective cesarean section. It started 4 hours prior to the time of elective section. How does the timing of infection during pregnancy influence outcomes? The timing. This is a very important question because timing makes difference with transplacental vertical infections that are teratogenic. Okay? But it doesn't matter the time of infection when it happened if the virus is not teratogenic for the baby. You catch my point, Shireen? For example, I'm very, it's a very critical point to know the time of infection with rubella, for example, or with varicella. But it's negligible risk affecting nothing in the outcomes with HIV, with HBV, and so on, because there are non-teratogenic infections. Aisha is asking, explain about CD4 count and viral load required start treatment. Look at this, it's very easy. The CD4 reflecting the immunity. So give prophylactic antifungal antibiotics first. If the viral load is high, so give antiviral treatment. Heart treatment with high viral load, antibiotics, antifungus with low CD4 count to save the patient's neck. You know, Aisha, patients are dying in HIV positive scenarios because of minute infections. The most common pneumocystis cranii in the lungs and the Clostridia difficile in the colon. So the patient may die from fatal pneumonia because of a very simple opportunistic infection. And he or she may die from watery, intractable diarrhea because of a very simple commensal in the colon, because I didn't give the patient cotrimoxazole. You know, the tablet is about 2 pounds, 2 Egyptian pounds. Okay, let's, I will take the last question. Considering the potential long-term neurodevelopmental effects of prenatal viral infections, what is the current understanding of the mechanisms by which maternal viral exposure alters fetal brain development? Now, most of viral infections in utero are affecting the brain development, and it represents with different pictures. Maybe with dolichocephaly, maybe with brain atrophy or hydrocephalus, microcephaly like toxoplasmosis and other viral infections. But the most, from your point of view question, the most common neurodevelopmental viral affection in prenatal infections is the cytomegalovirus. This is the most common organism or infection related to the sensory neural hearing loss due to neurodevelopmental problems. So it's common, but it has no treatment. CMV, you should just support the patient, symptomatic support, bed rest, fluids, and waiting for the lifespan time of the virus. And we can consider the risk for the baby, but we can never confirm the affection until the baby is delivered. This is why the neurodevelopmental problems are really considerable, because we cannot, in most of cases, determine the risk. However, recently, in the last decade, the fetal MRI of the brain is now playing a great role in evaluation of neurological problems and brain problems in utero. So we can depend on fetal MRI to take a decision regarding either termination of pregnancy or continuation with reasonable risk. Thank you, thank you. Common question, P for junior doctors. P for junior doctors, you have to follow the regulations of post-exposure prophylaxis for medical and paramedical personnel who are exposed to blood and blood products of suspected infection. And it should be conducted within 72 hours. You can contact the Ministry of Health hotline. They will very supportive and very rapidly acting regarding such scenarios indeed. What about emergency cesarean section when we give zidovudine? This is a last question and a very smart question. If you decided to do an emergency cesarean section with HIV positive patient, you have to start zidovudine even 30 minutes prior to the cesarean section. 4 hours is the ideal time needed, but it doesn't matter. I can offer the zidovudine for 1 hour, 30 minutes, 15 minutes. It will work, okay? And it will minimize risks of transmission. I have a question: routine screening for CMV rubella cases in recurrent miscarriage. Any rule in practice? I'm really sorry that the torch infections are not anymore a part of recurrent miscarriage reasons. So they are really important to be excluded prior to pregnancy because they are teratogenic in most of cases, but it's never related to recurrent miscarriage. And Professor Yasser, we can conduct a session about recurrent miscarriage as well, I think, because it's, like sometimes confusing topic indeed. Yeah, thank you. I think questions are endless.
Yeah.
either the topic is difficult or I'm a bad guy in teaching.
No, because it was a great lecture.
Okay. I don't know.
One last question.
I will take the last question. Sorry, my question outside the lecture. Oh, okay. I have patient para 3, 25 weeks gestation. Please, Dr. Yasser, Professor Sameh, be with me in this question because it's outside the lecture. So in this early second trimester abortion, her lupus negative, INR slightly decreased, doesn't matter. ELT slightly elevated with liver function normal. What is the case? Medically free only on folic acid. This is a very vague question and a very
Yes,
poor
exactly.
data provided, Fatma. I'm really sorry for that. But you are talking about a mid-trimesteric miscarriage. Is the baby was alive or not? Okay. Is it a miscarriage or is it a preterm, very early preterm labor? Is the baby is delivered with obvious congenital anomalies or not? Because this is changing the game. Okay. And regarding the blood tests, it's not all about acquired lupus antibodies. You have to think about the congenital thrombophilia, thrombin 3, factor 5 Leiden,
But
protein S and
do
C,
you
and
know,
so on.
Muhammad? Do you know, Muhammad, if you allow me, that's fine. So, just one thing that attract my attention, it's a little bit elevated liver enzymes.
I'm going,
So,
yes, sure.
to me myself, I think it's immunological condition. So I will ask for something very strange. I will ask for anti-nuclear antibody because this might be a case of systemic lupus erythematosus and complement 3 and 4. Could be. But I
Yes,
agree with you.
definitely, because
Yes.
the differential, exactly like what Dr. Yasser just said, because this is a very smart point. The liver functions, if they are moderately elevated, not severely elevated, we have to think about some autoimmune diseases, and sometimes we have to request anti-nuclear antibodies, anti-mitochondrial antibodies, because of the primary biliary cirrhosis and autoimmune hepatitis, which
And
may
the
play a
complement
role
3
as
and
well.
4.
But to
And
be honest,
complement,
my opinion, Dr.
complement 3
Yasser,
and
if
4.
it's like just a mild elevation of liver function, I think the first step is to repeat them because you may take some painkillers that increase or slightly increase liver functions temporarily. So as Dr. Muhammad saying, it's a vague question. We don't have a history. We don't have anything about the case except that she miscarried at 25 weeks.
That's why, Professor Sameh, I said if the liver functions are moderately increased,
Yes,
not
yeah,
simply
yeah,
increased. Because we have a
So,
lot of, if the patient is a smoker, the liver
yes,
enzymes will be higher than normal
exactly.
slightly.
so as you said, Muhammad and Samah, I think next week we will have the second part of this viral or infection during pregnancy and after that, so we can conduct what you said actually, a session for repeated miscarriage. So I think it will be
Yes,
so.
I
And as
agree.
you said, you will be responsible for it.
I agreed 100%. And it's too
Okay.
late to all of us. And thank you so much for Professor Yasser Abu Talib, the chairman of IRC-RCOG Egypt and the professor of Ops and Gynae Ain Shams University and Military School of Medicine. Thanks, Professor Yasser, so much for your time and effort.
Very much.
Thank you so much, Professor Sameh Salama, Professor of Gynae and Obstetrics, Head of Department in National Research Center for the Extraordinary Work. And I would like
Thank
to
you.
thank myself because I did a good
Thank you, Dr.
job.
Muhammad.
I would like again to thank the marketing house for the everything. They are taking a huge responsibility and they are really perfect in their job. Thank you so much. And finally, Pfizer, thanks again for this wonderful session and sponsorship. Keep the good work, and we will meet inshallah next week. Don't
Yes, it's
miss.
very important.
Yes, don't miss the next session as a continuation of this good work. Thanks, ERC members, Madam Jihan, and everyone, and have a good night. Bye bye.
Thank you.
Thank you.
Okay, thank you very much. Okay, have a nice day. Thank you. See you then. Bye.
Bye.
Bye.